Hi, I'm Colleen Bamford. Thanks for joining us for Health Watch In Depth. Our topic is dementia, a common problem with a growing older population. Joining me is Dr. Catherine DeBow, Dr. Sarah McGee, and Dr. Randall Morse, and all experts in this field. I'm going to get right into it with you, Dr. DeBow. Why do elderly need a specialized healthcare provider?
That's a great question. Geriatricians, which is what we all are internists or family doctors who have specialized in care of the elderly. And by elderly, it's not just by age. What we really can be most helpful for are people who have multiple chronic conditions, are on multiple meds, are starting to have problems perhaps with mobility, with memory, cognition, falls. So people who care becomes much more complex in a way, and we also, a lot of our work we do is focus on what are the goals of care for an individual. Not everyone's going to live to 110, or even if you are going to live, then what do you want to look like, where do you want to live, what do you want your life to be like?
Okay, all right. Can you add a little bit to that?
Sure. We work closely with agencies and organizations in the community. We're very well versed in the resources in the community and try to match the patient's needs with the resources to get them the help that they need. We try to keep them in their home as long as possible, as long as that's appropriate, and then work if we need to help them make a transition. We help them do that as well.
Okay. What are some common problems, common ailments with people as they get to a certain age?
Yeah, so this comes up a lot with the different issues that may come up for a patient, and one such may be functional status. And what I mean by functional status is their ability to take care of themselves, take care of their loved ones if appropriate, getting around within the community. And one of the big concerns that comes up with that is a loss of independence, so loss of autonomy, being able to rely on themselves to carry out those tasks that a number of years ago they might have just taken for granted.
What is the age? Because I know you hear of a very young 80-year-old or a very, old 68-year-old. I'm just using those in general terms. But Dr. McGee, what do you think? Is it really how you're feeling, what your family thinks about what you can and cannot do?
We don't really think about chronological age as much as we think about functional status and really functional age. So what is the person able to do for themselves, and what kind of functional impairments, as Randy had mentioned before. So we don't get too hung up on chronological age. Like you mentioned, there are many younger patients that may have a lot of functional impairment, and older patients that have less functional impairment. So it depends.
It sounds like it's all encompassing. You're looking at general practice, nutrition, exercise. So do you feel like that you're wearing many different hats?
We do, but we love to do that. And the other thing we bring in is expertise on aging and how it affects the body and different organ systems. And so we add that to our understanding of common medical conditions, the functional impairments that Dr. McGee and Dr. Morse have talked about, adding in cognitive impairments, and then just the complexity of care. They're going to probably multiple providers, as Dr. McGee said, need to access multiple resources. They're on multiple medications. So one thing we kind of do is help manage that whole piece for them, and with a real focus on quality of life.
Dr. Morse, as I mentioned in the beginning, I use the term dementia. What exactly is dementia? Are there different layers of it?
Yeah, so memory issues is a common complaint or concern that we have people approach us about. So whether it's in consultation or one of our patients in the office. And as you had asked earlier, what are the concerns? One is functional status. Another big one is memory. So a lot of people will say to us that I'm forgetting people's names or misplacing things, and they're not sure if that's normal, part of aging, or if that's abnormal. And that's what we try to discern when they come to us. So as far as dementia, I like to think about memory issues or dementia as a spectrum. So some people may have some what we call mild cognitive impairment, and this is typically maybe they have some memory issues they can't recall, or it doesn't really impact their functional status, taking care of themselves, taking care of others. Whereas now you move into along the spectrum to dementia, which there's lots of different types that Dr. Eisenstock will talk about later. And this is where it really impacts their function. Are they able to take care of themselves? Are they still able to do their own shopping, cooking, cleaning? Are they able to do their own grooming, for instance, or feed themselves?
That's where a lot of support services come in as well. But in terms of any medical treatments or therapies, Dr. McGee, I'll toss this question to you. What can be done, if anything?
For dementia?
Yes.
Okay. So there are some medications that are available that really have very modest effects. The effects of the medication really are to slow the progression of the disease, which is a progressive disease. And they don't make memory better, and they don't arrest the process as well. You know, unfortunately, the current state of the art right now, or state of affairs, is that the medications are not all that beneficial. They do help to keep people remain in the community for as long as possible, and that ultimately is the goal of many people, to remain in their own homes. So if you can slow the progression of the disease and help to maintain their independence in the community, then that is a positive outcome. You know, I think at some point there will be better medications at some point down the road, but at this point they're very limited in terms of their efficacy.
Okay.
So something else that's important is to focus on what are the other aspects of the patient, and to make sure that we're focusing in on those. So aside from medications, what are the other non-medication interventions?
Sure.
So we investigate what are the different social supports that they might have, who could help provide some support at home, and what are the other issues, and how has the dementia been impacting their functional status? Are there certain services that we can find within the community? Are there certain programs they can attend, like a day program? And also is what are the things that are going to lead to them needing additional care, such as a nursing home, for instance, which is one of the big concerns when somebody comes in with memory issues. So behaviors, for instance, is one of the big issues that comes up. And typically families will ask, well, what kind of medications can we give? But we first try to do non-medication interventions, whether it's music therapy, having a routine in place for them. One of the best things you can actually do is just reminiscing, and that's really soothing to people to kind of think back on what are the things that were important to them. And it may be difficult for caregivers to really just keep on repeating the same thing, the same experience in their head, but they have to take a step back and say, well, why am I doing this? It's very important to keep it patient-centered.
And I know that there have been some programs where groups of elderly are watching old movies, and I always wondered about that, but that's going right in line with what you're saying, to kind of trigger those memories.
Absolutely. Music therapy is actually very, very powerful as well.
Okay. How about, and is this maybe before it gets to a certain point, but we hear a lot about word puzzles and games to keep your mind focused and sharp. Does that make any difference?
Once someone has some cognitive impairment, certainly their ability to do those kind of activities are less. But keeping people engaged and active, and that's why we often encourage families to consider things like day programs, where there's going to be a lot of activities that are appropriate to people with some cognitive impairment. And it can be arts, it can be cooking, it can be types of exercise, but the last thing you want for someone with cognitive impairment is to be sitting home alone, because again, for the same reason the word puzzles become important before you get there, it's to really keep them going, engaged, using their mind as much as possible.
A lot of great information. Thank you. We're going to take a quick break now, and when we come back, we'll have much more on dementia and how it can affect you and your loved ones. Welcome back to Health Watch In Depth. We're discussing dementia, and joining me now is Betty Ann Warner, and your mother suffers from Alzheimer's. Can you talk to us a little bit about the first signs that you were noticing when she may be slipping a bit?
I actually noticed that about 15 years ago, so that she was 65 years old. She had just retired from nursing, and the first thing I noticed on Mom was personality changes. She actually was a little paranoid. She was quite different, actually. She called me once and told me that I was in her house yelling. She's 22 miles from me at her, and I'd never been there. So there were really dramatic changes in her personality.
Okay. Is that when, did you seek help right away, or did you sit down with her?
No, I tried with her husband,
Okay.
and I did try, and unfortunately they weren't open. She was defensive. It was actually 6 months later that my mother was hospitalized for food poisoning, and her admitting diagnosis was mental status changes. And at that point, my stepfather had told me he was doing the same kinds of things to her, but with food poisoning and the dehydration and all, it became manifest. And I did an MRI and certainly saw all the small strokes, and diagnosed her at that time with dementia, vascular dementia.
So where did it go from there once the diagnosis was made? I know that must have been a very difficult time for you, as well as what's the next step. Where did it go?
She was pretty independent for quite some time. So she continued to drive, and I took over to help my stepfather, who was a little overwhelmed with this whole process and in denial, I believe, most of his life. So I just took over doing all of her meds, bringing her to the doctor's appointments, noting the changes, finding the best help for her. We continued like that for the next 12 years, and then when he died, my stepfather, very suddenly, I took her home with me that day, and she's been with us since.
Did it get progressive, or
It did.
It did.
Oh, certainly.
Yeah.
Yes. But with Mom, I have to say it's, I think like a lot of dementia and Alzheimer patients, you have these periods where it accelerates, and then all of a sudden it stalls for a while, and then all of a sudden it'll accelerate it again. So it's kind of up and down.
We recently spent some time with you and your mom at your house. Can you go over some of the day-to-day activities, what you need to do to help with this?
Sure. We start in the morning by making sure she goes into the shower. I now have to adjust the water. I found out it was, she was taking a hot or very cold shower. Go in and, make sure she's safe. She soap, shampoo appropriately, so I help her with her activities of daily living. I watch her. I take out her raisin toast that she loves in the morning, and we help her with that. My husband, you can't do this alone. I have to tell you, he's been my rock, so we both care for her. When I accepted her in my home, it was both of us. So he's got the sense of humor. I'm kind of the mother. So we have a good balance.
Sure.
But, it's walking him through the activities of daily living. And then I have to tell you that I found a day club, a nurse manager friend of mine recommended Dodge Park Day Club.
Okay.
And they really have been an incredible resource. And I have to tell you, I don't know what I would have done without them, because you do need a few hours for yourself. Yeah. That's really important. And you have to work, you have to pay your bills. So, and the best part about it, she loves it.
That's great.
She wants to go every day. She gets up to go to school every day. She loves it.
I like that title, Day Club. It sounds like a spa club.
It is. She'll have her nails done. She had her hair done today.
That's great.
And she loves it.
That's great. So it really does take a lot of support services. How did you reach out and find them?
Well, I think it's hard for me. I think that's just a trait that I have, but I think a lot of us feel like we have to do it all. And I don't recommend that. It's okay to, I have 7 siblings. I'm the middle child of 8. And I have a sister in Maryland that comes up and gives us a week. You guys go away. Nice. She's raising her 8-year-old. We come for a week. And my sister locally takes her on Sundays for a few hours, so we can just go to lunch or do whatever. You have to be okay asking and reaching out. The other thing is the day club is amazing. You need some respite time. Go do whatever. They really encouraged us to take date time.
Yeah.
And you have to.
Yeah.
So we're empty nesters. We raised 3 kids. For 2 years, we had, no one. And then now we have a child again in the home, and providing that safety and maintaining her dignity. For me, I love her to death, but for me, the hardest thing is to remember that I'm not her mother. She's my mother. And I have to treat her as such, even though I want to treat her like a child, because she kind of is a child. But she always just turns to me and says, I love you, daughter. I love you, daughter. You know, and she's reminding me in her beautiful way.
That's nice.
Yes.
And what a key term, dignity. How is the communication? I know it must be difficult at some times that you
it's
don't,
so
again,
frustrating.
keeping that dignity,
Yeah.
not correcting her all the time. What do you do?
Yeah, I do get mad at myself, and I always say to myself every day, this day you're going to be a little more patient. You know, it's hard to be perfect. You have to step back and allow yourself a few mistakes. And I'm not always patient with her. Sometimes, you know, at the 18th time that in the last 5 minutes that you're reminding her, you know, Mom, Dodge Park isn't open yet. We got to wait a little while. Take your coat off and go sit down. You know, or you've already brushed your teeth, you know, 15 times in the last 5 minutes. That's a new thing. So, you know, it is really difficult. The communication, you really have to bring it down and break it down to very simple, direct. Bring it down like you're talking to a 2-year-old, obviously depending on where they're at in their journey. But with my mom, it's one command, very simple, eye contact, and just help her follow that through.
Okay. Do you let her go with it sometimes too, you know, if she's, as the other doctors were saying, trying to capture a memory, or if she feels strongly about something, how do you manage that?
That can be hard. She's usually okay because she is childlike. If I explain something, I did that, you know, she looks appalled. But I have to tell you what the physicians were talking about, the music therapy. The other thing that I do is pictures. I've compiled a lot of photo books. I just gave her a couple more for Christmas on her 80th birthday we just had. So she just, they sit there. She doesn't remember. She just looked at them and she oohs and ahs and flips the pages, and they jar a lot of memories. But the music therapy, I have to tell you, what my husband and I do, we play a lot of music for her, her favorites. And the most amazing thing is that my mother can't remember, you know, some of my siblings if she saw them in the grocery store, if they came over. But the words to the songs years ago, she can remember, and she can remember how to dance still. She was a beautiful dancer.
Oh, that's wonderful.
It's amazing. So.
Before we end this segment, what advice do you have for other caregivers?
Find a good doctor.
Okay.
I can't tell you. Dodge Park told me about Dr. Dubo, who you met tonight. And I have to tell you, she has changed our therapy completely. She has removed most of the medications except the really necessary ones. I've seen my mother blossom and come alive and be able to talk a little bit more, enjoy her life. She always says that, I love life. She's very happy. Yes. Finding someone, the first time I saw Dr. Dubo, she was sitting across from me, and at the end of the appointment, I'll never forget this, she turned to me and said, how is the caregiver today? I've never been asked that.
Wow.
In 14 years.
Yeah.
Yeah, that's pretty amazing. And I just was like, what? Oh, I'm fine, but what? But it's important because it's a family disease. It is, you know, it is those that you live with. It affects you all. And so you have to find someone that will treat all of you, you know, that will care for your parent or your loved one. And, you know, you have to remember, you have to take care of yourself too.
All right.
So.
On that very important note, I'd like to thank you for sharing all of this. I know it's been a difficult journey, but I'm sure you're inspiring and giving much needed advice to a lot of other people out there. So thank you so much.
Thank you.
We're going to take a quick break. We'll be back after this. Welcome back to Health Watch In Depth. Again, our topic is dementia. I'm joined by Dr. Jordan Eisenstock, who is both a psychiatrist and neurologist. Good for this segment. Let's get right into it. Dementia, there's a lot of different forms. The doctors in our earlier segment touched on that, but what are the levels that we see mostly?
So levels is an interesting way of looking at it. I think in general, when I talk to my patients, I discuss dementia as an umbrella term for any abnormal aging of the brain, you know, accelerated compared to the rest of the aging of the body. And I think that Dr. Morse touched on that earlier in the segment. And as far as levels, I'm not sure actually how helpful it is to think about different levels, except as we look at the different symptoms that might go along with the process. So for instance, in Alzheimer's, early on, we might see more of the word-finding difficulties that was already talked about briefly before, maybe early visual-spatial problems. And then as things progress, that's oftentimes when we start to see behavioral problems, agitation, aggression, and some of the other more complex issues that start to involve other kinds of doctors and specialists. And that's oftentimes as a neurologist and a psychiatrist when I become involved. So levels is somewhat accurate, but also somewhat misleading term, because all of these things can also happen at just about any time.
Sure.
And so we really just have to be very careful to keep our antenna up and pay attention to the symptoms that we see, so we know exactly how to deal with it as we go. I don't think there's one size fits all for anything. There's several different types of dementia. And again, it's an umbrella term. Alzheimer's is just the most known.
Yeah.
And in a lot of respects, especially where we're heading in our world, where we're aging longer, and frankly, I think if we all live long enough, we'll all end up with Alzheimer's, because it's an end process of the brain. But there are other types too. We talked earlier about vascular dementia and family experience with it. The other kinds that we oftentimes see and confronted with in very complex situations, even in neuropsychiatry, are patients with Parkinson's who might start with motor symptoms of Parkinson's, as you classically recognize, but then progress to have behavioral depression or other psychiatric issues that go along with it. So, in a sense, levels is very appropriate, and in a sense, it's better to kind of keep just a more open mind to pay attention to the symptoms as we go.
Okay, that's good clarification. Alzheimer's is the one that I think grabs a lot of people's attention, because it's scary when you're told a loved one or even yourself is showing signs of Alzheimer's. So how is that manifesting itself? Are there ways that you can treat that? Are there ways that you can identify that?
So again, this might be what made me interested in neuropsychiatry in the beginning, is that our brains are so complex. Again, there's no one-size-fits-all approach to any of this. But there are some common things that we see and patterns that develop, and it might inspire or impact the way we approach it from a treatment planning perspective. As a neurologist, I don't oftentimes see patients at the very beginning. It isn't until they've progressed a little bit, as you were talking about, with different levels and different symptoms that go on. But again, the early symptoms are oftentimes word-finding difficulties, naming problems. People forget people's names. And they might just sort of start to become more forgetful, need more reminders, more repetition. Sometimes spouses start to organize their appointments, and you just sort of slowly see this development over time. As far as what do we do about it? Well, the important thing I do think is to recognize, because at the end of the day, all dementias are effectively a clinical diagnosis at this point. We do have some testing that's out there, but not necessarily the most specific or sensitive in any way, shape, or form. Some people, when they come to see the doctor, expect either kind of the Star Trek variety, where you have this probe that goes over them, and all of a sudden something spits out on the other side. Here's your diagnosis, here's your treatment plan, and here's the recipe to fix everything. And then other people, still might have in some respects, simplified view of things, which we all, especially as doctors, hope for. Like a pregnancy test, plus or minus.
Yes.
Here it is. We know what we've got. But unfortunately, when it comes to dementia, we oftentimes find ourselves confronted with the uncertainty and how to deal with that from both a patient and a patient's family perspective, because that oftentimes is the most distressing part of it for everybody.
I read about a blood test, and I know that there's a lot of controversy or questions surrounding that. Is that something that doctors are looking at? Is that something that you were referring to as yes or no, a quick diagnosis?
So at some point it might be helpful. I think it oftentimes, like any test in medicine, is what are you going to do with the information? And just to have a blood test that might give us a more definitive answer about diagnosis is only helpful if there's something that's going to be sort of on the other end of it from a curative perspective. And at this moment, we don't have any specific cures for any dementias. This is a non-reversible situation from our perspective. There are other things we can look at that might be impacting it, and some of the ebbs and flows that we discussed before are very relevant, and actually a focus of neurologists is, what still, despite the non-reversible process, can you still treat. But at the end of the day, nobody that I know is ordering, a specific blood test. There are things out there, and oftentimes when things get confusing, we might try to supplement our clinical knowledge or our history and examination with this, that, or the next thing. But for the most part, it's not a recipe approach. There's no cookbook. There's no step 1, step 2, step 3. You really have to be individualized. If there was at some point a blood test, I think actually we'd probably have to be very careful how we use it. I would actually have more a cautionary approach than an excited approach to it. I'm sure at some point, and I do understand that we're close in a lot of ways, but I think we can't lose track of the fact that everybody's an individual, that the diagnosis isn't necessarily the treatment, and it doesn't necessarily suggest that you go this way, that way, or the other way. You really have to be both proactive and reactive at the same time, if that makes any sense. And I'm not sure necessarily that a blood test is going to specifically change the way we do things now.
Okay. What's a neuropsych testing, and how can this be used, or is it in dementia?
So neuropsychological testing is something that's still very commonly used in dementia. It's basically using tried and true tests that have been along for a number of years that are very sensitive and specific to pick up on different areas of the brain that might be impacted by dementia or the aging process in general. It's very interesting because in medicine we're starting to become more reliant on technological things that are higher technology. MRIs at one point, even nuclear imaging or other functional images that are out there for the examination of the brain. But I still think that at the end of the day, the pen and paper tests and some of the other more one-on-one testing that goes on with a neuropsychologist is much better. I order neuropsychological testing all the time because it provides several different benefits to both the patient and to the patient's family. So for instance, and this is the most obvious one, is for diagnosis. So when we do the neuropsychological testing, it's a lobe-to-lobe approach, and each part of the brain is responsible for some different function. If you see a pattern of, for instance, this part of your left side and this part of the right side, for instance, the middle part of your hemisphere, being dysfunctional or not up to par on both sides, that might be suggestive of a pattern. But same thing if it's more in the back or the front, for instance. And so it can help diagnostically, but I actually find that neuropsychological testing is more important for even more simple and basic reasons, because it actually tells us what are our patient's strengths and weaknesses. So even if they have dementia, I think the most important thing that we can do is highlight their strengths and help to mitigate or minimize their weaknesses. And so there's the power of knowledge in this case, especially for family members. We all know our family members, but we also know, and this is one of the processes of loss and grieving that goes on with dementia, as this person isn't exactly the same as we've known them all the time, is, how do we deal with this change? And the first thing is to know, well, what's changed? So I think in this case, educating patients and their families about, this is what really is still a relative strength, and this is really something where you have to watch out for, because otherwise it'll be a blind spot and perhaps get the patient into trouble. On a less significant or perhaps less significant side of things, it might lead to frustration for the patient because it's something that they might have been good at before that aren't now, and we certainly want to minimize those kinds of stressors. But even on a more, or on a deeper safety level, to know where those blind spots are and to be able to avoid them can help us in a much broader approach to keeping them healthy from a whole body.
Can you give me an illustration, an example of how to capture those strengths if you're looking at a part of the brain that seems to be strong? What can you do? How can you bring the best out in that?
Well, I think it's important to always put the patient into a situation where they can actually feel those successes and know that they're doing well at something. Okay. One of the things that we do know in the study of dementia is that the more limbic or deeper parts of our brain, where our affect and our emotions are probably not affected quite the same way, or at least much later. So even if someone can't necessarily verbalize, their feelings, they still are feeling things. And so I still think that they feel successes and they might feel failures. So again, in an effort to minimize them and to accentuate, putting them in a situation where they're going to be most successful and feel the most joy is important. And that comes in lots of different varieties. But again, there's no one size fits all. I think that's the most important thing that we have to teach our families, is that this approach might be right for this person, but not for that person. For the most part, though, conversations that I end up having, especially as we're reviewing neuropsychological test results, is about day programs. It's likely, not scientifically proven, but likely that patients benefit more from social interaction and being around other people in their cohort and their age groups and going through similar things and just maintaining those human connections than any medicine that we prescribe. And so, so that's something that I use the results to guide us with. Back to your original question about what else do we do with neuropsychological testing, because it's kind of endless. I probably could go on forever about this.
It is fascinating.
It is, and it's so helpful, and it's so simple. Again, it's not the most expensive test out there, and it is just so valuable. But the other thing is as a true cognitive baseline. So again, in the theme of everybody's different, everybody progresses differently, and nobody's ever going to follow the same pathway, we need to follow each person. And the best way to do that is to establish a starting point and to have a baseline study. And so even if we're not going to get a diagnosis out of it, nor do we expect a diagnosis, just doing the neuropsychological testing for the first time can be very helpful because, again, we know a patient's relative strengths and weaknesses. We have some percentile numbers. We don't care how they stack up against every other patient who's ever taken the test. But when they take it the next time, and we can see how they've done or progressed over a year or 2 years or 5 years, we actually get much more information. And in fact, it helps to inform treatment, but also helps us to answer some of the more difficult questions that family members naturally have about progression. Instead of leaving everything up to subjective feelings or here's what I'm seeing or, yikes, we can actually have some objective measure to say, no, your family member is just about the same here, maybe a little bit worse here, a little bit better there. But then again, circling back, those are things that we need to stay up on because the brain is constantly changing. So if we still want to mitigate weaknesses and accentuate strengths, we need to stay current for that person as well. So the neuropsych testing is actually not just a one-time thing. It's probably a process of having maybe 2 or even 3 tests over a lifetime.
Okay. Just my final question. Your expertise is a lot different, or just supplements what they're working with geriatrics and how they're working with the caregivers. Does every patient see someone like you, a neurologist or psychiatrist, or is this a more advanced patient?
So I'd be careful not to use the word advanced,
Okay.
and definitely not every patient.
Okay.
Our value can come in lots of different shapes and forms, and hopefully we're adding value all the time, though it can be different. And I think for that reason, there's no predefined definition for what's the role of a neurologist or a role of a neuropsychiatrist or a role of a psychiatrist. I think we have to be able to flex the patient's needs. Oftentimes, though, when we do become involved is when there's questions regarding diagnosis, and not just about what kind of dementia we're dealing with, but is this actually an irreversible process, so a dementia like Alzheimer's that we have no cure for, or is this more of a reversible process where it might be the product of a stroke or some other neurological brain disease like multiple sclerosis or CNS vasculitis or some kind of inflammatory condition. And so I think that our value sometimes is in just teasing apart or peeling away the onion and trying to understand what can be a very complex but otherwise homogeneous looking patient. A lot of the word before or the diagnosis before that was used was change in mental status. And I think that oftentimes that is just obviously very broad. What does it mean? What is the reasons for the change in mental status? And that's where we might provide value. At the very beginning, before someone's actually got a definitive diagnosis or a probable diagnosis even, that comes into play. But it might even come into play a little bit later on where a patient might actually have an infection that's causing them to have a change in their thinking or their behaviors or their personality. And the question arises, is this something that we can fix with some other treatment because it is in addition to but not because of someone's dementia? And so I think that's oftentimes where we the most frequent time, how's that? The most frequent time where we become involved. There might be other times too, especially as a neurologist and a psychiatrist who takes pride in knowing all of the neuropsychiatric meds. We might also have some value in helping to actually simplify a patient's medication regimen. So one of the things that oftentimes happens over time kind of like the basement or the attic of our houses. It's just easy to keep filling it up, and that's oftentimes the default. And we can not in any malignant fashion, but we can oftentimes see a patient's med list go from here to here very quickly, and just trying to decide what's actually important and what is necessary, what can be tapered or even completely discontinued, what two meds might be able to be consolidated into one med and have fewer side effects or other benefits, frankly, for the patient. And so those are some of the more common points of interaction where we get involved.
Okay. Very good analogy to end on. Thank you so much. And you used the word complex. Complex is really what this issue is, and hopefully we've scratched the surface or gone a little bit below that to give you the information that you or your loved one needs when dealing with dementia. That's Health Watch in Depth. I'm Colleen Bamford. Thanks for watching.